Okay, so now we're going to get into new material. So before we start, I do want to be sure you know about the pending assignment. So for Monday's section, that means you have to finish the Neuro ATI Part 2 before being able to take the exam. Monday's section will have the third discussion board, which will open up today, and there's actually only going to be one post which you will have to complete prior to the start of the next class, and then the Discharge Project, and both sections have that, and that is where you're going to record a very short video of yourself explaining a medication as if you were discharging the patient. So everybody will receive one medication. And then I will ask you a question that you will have to answer. So there's going to be a separate document with the assignment directions for this. It will be a way to help us review for the final. And so I do encourage people to watch the videos as a way to be sure, see if you're getting the right information. And so there'll be a separate document with directions on how to upload your short video onto something called a Padlet so that we can all see them. And then obviously study for exam 4, which is going to be on all the neuro medications in the last part of the respiratory section. And that'll be next class. We'll do it like we did last time. There is a time limit for the exam. You have to, again, check in so that you can get the exam password, and that has to be done at the beginning of class. Okay, so now we will get into the new stuff. So the first neurologic conditions we're going to talk about are the ones that are called degenerative disorders. So things that start to affect brain functioning. The first disorder we're going to talk about and the medications used to treat it is Parkinson's disease. So just a little bit about Parkinson's disease itself. It is a destruction of a part of the brain called the basal ganglia. And this part of the brain is important because it helps to smooth out movement and helps your posture and helps to relax movements after you've started the contraction. Sort of the balance to your somatic nervous system, your voluntary movement. And that's how you should imagine it. The voluntary movement occurs because of the release of acetylcholine affecting the cholinergic receptors, and so muscles contract and you start a movement. This sort of runs interference in the background. That's dopamine, which is produced by the basal ganglia to smooth movement out, to help relax movement when the contraction is over, as well as to help maintain posture. So we want a balance between these two neurotransmitters in release in the brain. What happens with Parkinson's disease is there's some sort of degeneration of the basal ganglia. It can be related to trauma, drug use, could be genetic condition. Sometimes we don't know what causes it. It does tend to run in families. It can at least. So this area breaks down, so there is an imbalance between the amount of acetylcholine in the brain and the amount of dopamine. So it's not that the body is making more acetylcholine, it's that we've lost the dopamine. And that's why it seems like there's a higher amount of acetylcholine. It's just that we don't have the balance anymore. So because of that, you get the symptoms of Parkinson's disease, which is a stooped posture, difficulty starting movement, difficulty relaxing once the movement is started, very rigid, hard to get the person to relax their muscles afterwards, and tremors when they're trying to move. Those are called intention tremors. So you don't just have them all the time. It's when you try to do something. So if we want to treat this condition with medication, we can try to decrease the amount of acetylcholine to try to get the balance back, or, which is the usual way to treat it, increase the amount of available dopamine. Either way, we're trying to get the balance back between the amount of acetylcholine and the amount of dopamine, and that's our medication goal. Anyone who's on these medications, and this is key for you in the exam, should know that you're not going to cure Parkinson's disease, you're only going to improve it. Which means that the person with severe Parkinson's disease, as it gets worse, has a hard time performing the activities of daily living, ADLs. It's hard for them to care for themselves. So when you're on the medication, that's what you're hoping to do, is improve their quality of life, improve their ability to take care of themselves. So people should know that there is no cure for Parkinson's disease. We're just trying with medication to make their life better. So, because we know that Parkinson's is caused by an imbalance between dopamine and acetylcholine, we use medications to either increase the amount of dopamine or decrease acetylcholine so that we can balance the scale for movement. So the best treatments are increasing the amount of dopamine, which are called dopaminergic medications. And there are others in this class that are newer that might be slightly different on how they affect dopamine. But and for the exam, you have to know levodopa, carbidopa. So levodopa is actually synthetic dopamine. And you take that medication by mouth, it's a pill, it gets absorbed into the circulation and has to cross the blood-brain barrier in order to affect the brain itself. That's where you want the dopamine to go. The reason it's paired with carbidopa is because levodopa gets broken down in the peripheral system and you won't get as much dopamine in the brain. Carbidopa helps prevent the breakdown of levodopa in the peripheral circulation so that it can get to the brain and have its effect. So levodopa is really the medicine that we want because it's dopamine. And carbidopa is helping us get more of the levodopa into the brain. So it's a PO medication. We know and should counsel the patient that this is not to cure their Parkinson's disease, but to make it easier for them to do the activities of daily living and help their quality of life. So these are the main side effects: orthostatic hypotension, dizziness, and something called tardive dyskinesia. So right away we can see patients that we have to worry about. If it causes orthostatic hypotension and the patient also has hypertension is being treated with medications, we have to worry about that combination. So those people need to be counseled to change position slowly. And we need to watch what their blood pressure does when we're on this medicine. This together on a patient with a stooped posture and a change in the center of gravity makes them a huge falls risk. And so they should be talked to about that so that they are safe when they change positions. Tardive dyskinesia is a particular type of repetitive movement that particularly affects the face. It can be like excessive blinking or lip smacking or sticking out the tongue excessively. Sometimes this shows up, and when you stop the medication or change the medication, the symptom goes away. Sometimes it's permanent. People don't like that because obviously everyone can see it, and it's a reminder, that you're on these types of medications. However, it does make it easier. Medications themselves make it easier to dress yourself and eat, so you kind of have to balance what you want. But that is a troubling side effect that people will sometimes change medicine for. You do a lot of times what'll happen is someone's on this medication and they start to feel like it's not helping as much. And one way to help that feeling is to take a drug holiday. However, you should never abruptly stop levodopa carbidopa. You should wean them off, let them have some time off the medication, restart the medicine, and they will have a better response again. So on the slide, it mentions cautions with antihypertensive medications, which we talked about. You want to be sure, this is unusual because usually we say antacids, calcium type of stuff should be avoided because that decreases absorption. But for levodopa carbidopa, that actually increases absorption, so they're at risk for toxicity. And toxicity of this would affect their blood pressure and their level of consciousness. And the other issue is we have to monitor liver function because it can start to affect liver function itself. So we know that those labs are the liver function panel, which is AST, ALT, bilirubin. And we know symptoms of liver disease are abdominal pain, decreased appetite, jaundice, light stools, dark urine. So sometimes this can be added, or if for some reason the patient can't use the dopamine drugs, you can use benztropine, which is cogentin. You might have heard it named that. What that's doing is trying to alter the balance by decreasing the availability of acetylcholine in the central nervous system. So, like all drugs, we wanted to target the central nervous system inside the brain, but we know that no drug is as specific as we would want it to be. So it could potentially target parasympathetic activity. And so when we're thinking about side effects and cautions, we can think about the same things that we did for anticholinergics. So we had to be careful for benztropine. We have to worry about the hypertensive tachycardic people, because that might increase. So you have to worry about coronary artery disease, that's the pupil dilation, the dry mouth. GI-GU will be decreased, so we have to worry about people with poor functioning, to our BPH patients, the glaucoma patients. And because it's an anticholinergic, we have to think about medications that are cholinergic because they're going to be canceling each other out. So if the patient is taking a cholinergic medication, like for their myasthenia gravis, then we would have to worry that these two are canceling each other out. So that wouldn't be a medication you could use. Alzheimer's disease is another type of neurodegenerative or brain degenerative disorder. It's different than Parkinson's, though. What happens is there's a buildup of what's called an amyloid protein and a change in what are called tau proteins that help stabilize neurons. And there's genetic reasons for that. It does tend to run in families. Some of the reason this occurs is unknown. But what it amounts to is a change in the beginning in your ability, your short-term memory, and what's called your executive function. So you can do the usual things like activities of daily living, and you remember things from the past, but you might forget where you were going, or that you have something on the stove, or you might not handle your bills, or things that are a little bit harder that require higher brain function. And that's what happens first. It's very easy for people to cover some of that stuff by saying, oh, old age forgetfulness, or either isolating themselves or becoming angry with people and saying, I'm not having trouble with remembering things. You're the problem. So where that occurs, some of these higher functionings, and where one of the areas where we start to lay down memory is in the frontal lobe of the brain, or the higher areas of the brain. And this is nerve to nerve activity inside the brain. And that nerve to nerve activity uses acetylcholine. So here's the presynaptic neuron, acetylcholine packaged inside the nerve. And acetylcholine will be into the synapse to interact with receptors, which will be cholinergic receptors on the next nerve, to help lay down memory or to help with some of these higher level functions. So if this nerve or other surrounding nerves are having issues with functioning, they're degenerating or scarred or part of an inflammatory process or whatever, then the nerves that we have that are working, we want them to work better. So we use cholinergic medications, specifically medication that inhibits the activity of cholinesterase. So that should sound slightly familiar because pyridostigmine is a medication that inhibits cholinesterase in the synapse between the nerve and the skeletal muscle, and that's what we did to treat myasthenia gravis. If we keep acetylcholine inside the synapse longer, then we have an increased ability to contract skeletal muscle. Well, the concept here is if we keep acetylcholine in the synapse longer, perhaps the nerves that we have will work better in terms of memory and executive function. So we're doing a similar thing, just in a different area of the body. We're going to inhibit the enzyme that breaks acetylcholine down, so acetylcholine stays in the synapse longer and hopefully improves these functions. And the medication that was first came out to do that is something called diazepam, which is Aricept. That's the brand name. So it is considered a cholinergic medication. Obviously, it's supposed to be selective for the central nervous system in the brain, but we know that no drug is as specific as we would like it to be. So we might have some of those cholinergic type effects. And at least there might be interactions between cholinergics and any anticholinergics that we're taking. So this medication is best used in the beginning when the person first starts to have memory issues. Sometimes it's hard to find those people though, so you don't always get the best benefit. Diazepam is not effective. It does not help people in the later stages of Alzheimer's. It's really not going to do anything for them. It can cause hepatotoxicity, so it's another one we have to worry about liver function in terms of signs and symptoms of hepatotoxicity and monitoring liver enzymes. And even though this doesn't quite make sense when you think about it, it does cause, excuse me, it's contraindicated in people with peptic ulcer disease. So put stars around that. That's kind of a weird thing, and it always shows up on the exam. People who have a history of ulcers in their upper GI tract or lower GI tract have had a GI bleed in the past, if they use diazepam, that tends to make it worse. So there'll be a question, because it's never going to be as simple as peptic ulcer disease. There might be a question: a Alzheimer's patient is taking diazepam and they start to develop black tarry stools. That would be concerning, even though it's kind of weird, like, oh, we're talking about this central nervous system medication. It's a weird thing with diazepam, and that you have to be aware of. So it's very likely to be a test question. So keep that in mind. Lots and lots of stars around it. So the next section, before we move on to mental health stuff, is seizures. So seizures are caused by an increase in electrical activity. Increase in electrical activity focus inside the brain. So you get abnormal nerve impulses. And depending on where that area is and how large of an area it is, depends on the presentation of the seizure. So there are different types: partial, generalized, or seizures related to specific syndromes. So they're partial, they can just affect one part of the body. Generalized, you'll see that's absent, tonic clonic, and atonic. So absent, sometimes people just sort of stare off and get blank. Tonic Clonic is the classic seizure where there's muscle contraction and relaxation, the spasming. The epilepsy itself depends on how, the presentation is very varied. It depends on where the activity is, how often it occurs. For some people, it's very debilitating. For some people, it only occurs every now and again. There are medications that can be taken to decrease seizure activity. There are also procedures that can be done, like removing the seizure focus in the brain, things of that nature. So you want to know what a seizure looks like. There are people that try to fake seizures. It's called pseudo-seizure. It's really hard to fake an actual seizure. So people who pretend to do seizures, that's pretty obvious. But an actual seizure will have certain characteristics. Whatever that presentation is, usually after the seizure is over, the person has what's called a post-ictal phase. Like after the seizure, there's usually some degree of fatigue. Depending on how large the seizure is, that phase can be rather long. Depending on how generalized the seizure is, they might have incontinence as well. So medication is aimed at decreasing seizure activity. So if we know that seizures are because of an increase in electrical activity, and electrical activity in the cell means the action potential, so we're making the cell positive, then the medication management is really to decrease electrical activity, to keep the cell more negative, so it's harder to generate that action potential. And so the classes of medications we're going to talk about are the different ways to keep, hopefully just seizure nerves, more negative. So we can either increase the amount of chloride that gets inside the cell because that's a negative ion, so the cell is more negative. Or we can change how sodium or calcium can get inside the cell since they're positive. If we keep them out, then we can keep the cell more negative. So altering the charge should kind of make you think of the antidysrhythmics too, because remember that was an issue where there was overactivity or underactivity of the nerves, the conduction system of the heart, and this is what we did. We changed how ions could go in or out of the cell. It's the same thing we're doing for seizure activity. So the first group of medications are the ones that manipulate chloride, which is a negative ion. So we're making the cell more negative. They work on something called the GABA receptor. The GABA receptor is what signals this chloride channel to open. So if I would stimulate this GABA receptor, then the chloride channel is open and chloride can go into the cell, which is negative, keeping the cell more negative in the central nervous system, decreasing the electrical activity, and thereby decreasing the seizures. These are some of the older treatments for seizures, and you don't see them used on people as much anymore. Phenobarbital is often used on pets who have seizure activity. But the two categories of GABA medications that act like GABA or GABA receptor agonists are barbiturates and benzodiazepines. So phenobarbital is our prototype, diazepam is our prototype. You will see these used in practice, and primarily benzodiazepines, for people that have a condition called status epilepticus. This condition is an emergency. That means the person is having continuous seizure activity. And the person will become exhausted, and it can lead to airway and respiratory failure as well as cardiac arrest. So we want a person who is in status to stop the seizure activity as soon as possible in order to help them. And so we do see, especially benzodiazepines used in the emergency setting, stop continuous seizures or status epilepticus. That might be where you would see it used for seizure activity. So the first medication, our phenobarbital, which is our barbiturate, is given usually IM because of its possibility if it leaves the vein as a vesicant. So we try to avoid IV just to protect the patient's tissues. Because we're causing CNS depression, we are stopping seizure activity, but we could develop respiratory depression as well, and we really will sedate the patient. This is a pregnancy category D, and like I said, is not usually used anymore for regular seizure activity, just to prevent seizures in general. The other class medication is benzodiazepines, and diazepam is our prototype benzos, and then PAM. This medication, this is Valium. It can be used PO, IM, or IV. It has other uses. It's a muscle relaxer too, so sometimes people use PO versions for that. It could be given IV in order to knock the person out of status epilepticus, which is when it's usually used. However, we have to worry about the respiratory depression, just like we did for phenobarbital. So that means we need to monitor their respiratory rate every 5 to 15 minutes. And we have to be careful about the E of our airway breathing ABCs. So sometimes people that are in status epilepticus that end up getting high doses of benzodiazepines will end up intubated or on the breathing machine because of the respiratory depression. So this is the person that if you saw them with a low respiratory rate and a low oxygen level, we can't just put them on oxygen and expect to get better. Because the problem is they're not breathing. So this is the person that needs the ambu bag or the ventilator to drive the breaths in, because that's the problem, is they can't do that. Much like when we talked about the opioids and morphine when someone has too much of that medicine. Okay, the next grouping of medications for seizures are those that don't allow sodium in or decrease the amount of sodium that can go into central nervous system cells, which make them more negative and decrease electrical activity. So all of these have the potential to cause sedation. That's the common side effect of anti-seizure medicines. So the first one we'll talk about is phenytoin, which is Dilantin. It can be given IV or PO. When it's given IV, it is a vesicant, so we have to be very careful about giving it IV. You should use a large vein or central line. It can only be mixed with saline because if it's within a dextrose solution, it will precipitate, meaning it'll become solid and could cause an embolus. So when giving phenytoin IV, that's why there's a separate slide for that, there are several rules to be concerned about. The other thing that you'll see with all of these is they are pregnancy category D, same as phenobarbital and diazepam. So phenytoin has a narrow therapeutic range, 10 to 20 micrograms per milliliter. So that means if it's less than 10, patient probably still has seizures. 10 to 20, we're good. Over 20, we have to worry about toxicity. So the main side effects, besides sedation, well, is also decreased blood pressure. So we have to worry about our hypertensives if they're on medicine for that. And gingival hyperplasia, which is not terrible. It just means we have to be certain that they're doing good oral care. Toxicity means the sedation and blood pressure are profound. So profound hypotension, change in level of consciousness, slurred speech, confusion, all the way up to coma and dysrhythmias. Extra stuff that can happen is it can bring the blood sugar up, so we have to worry about our diabetics and be sure that we're monitoring them closely if they need a change in their medicine. It can decrease their white blood cells and their red blood cells, which means we increase risk of infection potentially and anemia, and can cause that severe skin reaction, Stevens-Johnson syndrome. So that is some of the highlights of the phenytoin. Carbamazepine is another sodium blocking medication to decrease seizure activity. Again, the main side effect is sedation. This medication can be given, usually given with meals. It's a sustained release, so you have to swallow it whole, no grapefruit juice. Always have to worry about sedation. Other adverse effects include both those toxic skin reactions, Stevens-Johnson syndrome and toxic epidermal necrosis, visual changes, bone marrow suppression, so that means decrease red blood cells, white blood cells, and platelets, as well as fluid retention. So it's contraindicated in people who have heart failure because we don't want them to have increase in fluids. So if we were in class together, I would say, so what are the symptoms of Stevens-Johnson syndrome? And that's 7 to 10 days after starting the medicine, patient has symptoms of an upper respiratory infection, followed by kind of on the torso, a pimple-like rash that becomes diffuse. Toxic epidermal necrosis is a rash in the entire skin, and then that sloughs off, that top layer of the skin dies, and you can just kind of pull it off. Symptoms of CHF depend on where you're retaining fluid. If you're retaining fluid in the lungs, that's crackles, coughing, sputum production, shortness of breath. Retained fluids in the system, that's dependent edema, lower extremity, increased weight, increased blood pressure. Bone marrow suppression, we said decreased white blood cell increases risk of infection. Decreased red blood cell is the symptoms of anemia, and decreased platelets makes it easier to bleed. So keep cycling that in your head like I would make you do in class, because you have to associate these things with a particular patient. Otherwise, you're not going to do well in the exam. Then the last medication in this class where we're blocking sodium is valproic acid, which is also called Depakote. This is also IV or PO. If it's a PO, you cannot, so put stars around that, use a soda or carbonated beverage because you'll burn the inside of the mouth, and you can't chew it for the same reason. But this is one of the only medications that you could actually open up the capsules for people who have difficulty swallowing it and have them have it in like ice cream or applesauce or something like that. Again, pregnancy category D. Again, you have to worry about sedation. This also causes photosensitivity, so you have to worry about people in the sun. Adverse effects, bone marrow suppression, just like this. Increased bleeding time, so they have a definite increased risk for bleeding, so that'll probably be a test question. And the potential for liver toxicity, so they're going to need to have their liver function monitored while they're on this medicine. The last medication that we're going to talk about for seizures is ethosuximide, and this suppresses calcium entry into the cell. Again, calcium is a positive ion, so the cell is more negative. Like all seizure medications, we have to worry about sedation. For this one, we also have to worry about the sun exposure. Ethosuximide is the prototype, but there's also lots of medications that do this that you might see, and any seizure medication you might see used for mood stabilization as well. The other one is lamotrigine, which is Lamictal that you might see more. Pregnancy category C. So this is the one that might be a good one for people that are of childbearing age or are pregnant. This is a PO medication, and now we have to worry again about bone marrow suppression. So that's decreased red blood cells, white blood cells, and platelets. New thing here is a concern about behavior change, psychosis, or increased suicidality. So we have to talk to the patient about that as well as their family. And then hepatotoxicity. What I would usually do in class would be to try to help you pick out those special categories of problems to make it a little bit easier to remember all these medications. So what I would do is talk about different categories and see if you can remember what goes where. And I encourage you to do this at home too. So most of the seizure medications are pregnancy category D. The only one that's C is ethosuximide. Respiratory depression is particularly a problem with phenobarbital and diazepam. In fact, we talked special about that with diazepam. Stevens-Johnson syndrome is phenytoin and carbamazepine, whereas toxic epidermal necrosis is carbamazepine only. We talked about phenobarbital and phenytoin as being the vesicants, that there were rules for IV administration of phenytoin in particular. Phenobarbital, we should try to give IM because of that reason. If we're giving phenytoin, it has to only be in saline, large vein, central line if possible. Bone marrow suppression, the sodium and calcium medications can cause that. Liver toxicity, carbamazepine, valproic acid, ethosuximide. We have to worry about toxicity in terms of too much of the medication, an overdose of the medication with phenytoin. Remember, it's 10 to 20. So try to break them down into pieces because those are generally how test questions are phrased. So just, I would, that might be another way to help study.